Rural hospitals are community strongholds, serving as the key point of care for nearly 20% of Americans. Beyond providing healing and hope, rural hospitals nationwide are pillars of their local economies, creating essential jobs that support families and community vitality. The emergence of COVID-19 has created unprecedented challenges for the U.S. hospital system. As frontline responders, hospitals have significant responsibilities for identifying and treating patients with COVID-19. Hospitals around the country are adapting to the constantly changing face of the COVID-19 pandemic by adopting both expected and novel strategies to tackle the crisis. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hedderly, senior writer for AHA. Recently, AHA published a compendium of case examples demonstrating the struggles and successes of rural hospitals battling COVID-19 in their communities. For this podcast, we honor our hospital heroes and focus on surviving the surge from the perspective of Tim Putnam, CEO of Margaret Mary Healthcare in Batesville, Indiana.
Good day. I am John Supplett, Senior Director of Rural Health Services for the American Hospital Association. Today, we will hear the story of hospital heroes caring for COVID-19 patients at Margaret Mary Health, located in Batesville and serving Franklin and Ripley counties in Indiana. MMH is a not-for-profit critical access hospital employing nearly 850 team members and serving a population of more than 30,000 residents. Tim, I know you are in the thick of the battle against COVID-19, but there is much our rural hospital colleagues can learn from your early experiences. Thanks for taking the time to share your story with us today.
I'm glad to, John. I hope some of the things we've done, both successes and failures, other people can learn from and be more prepared for this than we were.
Tim, Margaret Mary Health reported its first positive test for COVID-19 on March 22nd, predating Governor Eric Holcomb's executive order to stay at home. How did COVID-19 reach Franklin and Ripley counties so quickly?
Well, the patient that tested positive on the 22nd actually presented to our team on the 13th, and that was Friday, March 13th. And to answer your question, honestly, I believe we were just unlucky. That was a patient that presented with odd symptoms. That was general fatigue. It wasn't classic viral, what we would expect from a viral lung disease. It hit us so hard and hit us very quickly. Toward the end of March, we were actually seeing up to 9 or 10 patients test positive a day, and we'd have 6 patients on ventilators, 2 on ventilators in the emergency department at one point in time.
Then 2 days later, on March 24th, you reported that several employees and clinical caregivers tested positive for COVID-19. How did you adjust to staffing demands as the surge continued to grow, and how did you keep your staff safe?
Well, that was very disappointing and really hard from a leadership perspective to see people I work with on a regular basis and people I know fall ill to COVID. It was really hard when we learned that the disease presents in such ways as headache, backache, general fatigue, things we weren't wearing masks for at the time back in March. It's hard on multiple levels. It's hard on a personal level with fewer than 1,000 employees here. I know virtually everyone. To see them fall ill was really tough, but you also have to realize in a rural hospital, we've got a very small bench. For example, I've only got 4 OBGYN physicians. And on one day, 2 of them fell ill with the same COVID-like symptoms. So you end up going from 4 OBGYNs to 2. And we really have a shallow bench in a lot of areas. It required me to work with a lot of community hospitals to say, if I lose another OBGYN, can I borrow one? If all my surgeons go out or all my ER docs go out, how do we work on this together? And it's really been a teamwork effort from other hospitals. To keep the staff safe, we've really gone to an all-mask policy with all patient interactions.
Tim, you mentioned that your staff has the competency to care for COVID-19 patients, but you're hamstrung with limited bench strength. So if staff members get ill and are no longer available to you, how did you make accommodations to ensure that care was still available at Margaret Mary Health?
An example could be your respiratory therapy department, or like I mentioned with OBGYN. We've had an association with 8 other community hospitals, and when we started to see people in one area exposed or fall ill, it was a quick call with that group to say, can you share staff with me if I get into a crunch? And one thing I've learned, John, and during a pandemic, there are no competing hospitals, and everybody's willing to step up. There's a lot of things that were waived to allow nurses, doctors, and other professionals to be able to move from hospital to hospital. So creating that bridge was really important. Now, we didn't have any departments that went to zero and need to pull that string, but it really was, from a leader's perspective, important to have it in place should we need to do it. And it's reciprocal from my hospital to those others if they get hit as hard as we did.
Now, did this hospital network, does it exist in advance of the COVID-19 pandemic? Was this something that you had in place prior to this experience?
Yeah, this is the Suburban Health Organization in Indiana, a group of hospitals that do a lot of things together. And one of the best things we do together is help each other become stronger as hospitals. So open information sharing, open support.
You also mentioned that when patients present, that they didn't have the typical symptoms or the symptoms that were often associated with COVID-19. Tell us how that learning curve went as you treated patients in Margaret Mary Health.
The best way I can describe the surprise was a CT technician that said the first 3 patients where she found the existence of a chest CT that showed ground glass in the lungs, or basically the classic sign of COVID, they first came in with abdominal CTs because they presented with abdominal or nausea or complaints from that perspective, not respiratory. It's at that point that we realized this is not a classic respiratory issue. We'd heard of that before, but we heard it as an odd symptom, not the presenting symptom. We had a patient that presented with backache as their primary symptom, and within a day tested positive for COVID. We've had patients present with headache and within a few hours had to be intubated. It's a disease that I don't think some of these symptoms that we saw early on have been well documented or well publicized.
Tim, as the surge grew across Franklin and Ripley counties, how were you then able to secure the necessary testing supplies or the ventilators or equipment and to build the capacity necessary to treat this surge of patients? How did you improvise?
On everyone here at Margaret Mary's job description is other duties as assigned. And I think that's where that fell in. We really empowered our directors, our managers, and our frontline team staff of what is going on and how do we get the resources. So we had someone in our leadership that knew someone in Tennessee that repaired ventilators. And he made a call, do you have any that are repaired that are not out for sale yet? And we got a shipment of 10 ventilators in here. Hospital beds are pretty easy because we're the headquarters for Hillrom Manufacturing. So there were several options we had for expanding beds, but other things like testing supplies and masks, our team had to get creative, and we empowered everyone. How do we get to a resource? So that's finding places that sell masks to engaging our community seamstresses and to making masks that we could use. It really is about empowering everyone to be part of the solution.
Margaret Mary Health has created 2 alternative care sites, one at Batesville Primary School and then another at an orthopedic specialty center. What is the strategy behind these alternative sites and how has it worked?
The primary reason was to separate our potentially acutely ill or possible COVID patients from the people that were coming in for chronic diseases or going into their obstetrician or coming in for a surgery consult. How do we separate that out? And they were all done in one building before. So we saw the need to separate the acute patients from the needy but otherwise healthy patients. We'd had a video telehealth setup with a school nurse already in place. So we built on that and built that into a care site that we sent possible COVID patients or anyone with an acute onset that wasn't going to the ER. Same for the orthopedic specialty center. So we were able to send staff there and use our physicians to be able to evaluate those patients either in person or through a telehealth site. That was really important, and I think gave some level of comfort to the new moms coming in or people coming in that needed to see an oncologist or an orthopedic surgeon for something, that they weren't coming into an area with active COVID patients.
Tim, you've mentioned a number of collaborators in this experience, various organizations across the community who have contributed to the treatment and care of COVID-19 patients. How did you coordinate communication across all these collaborators?
Well, this is the benefit of living in a rural community. Everybody knows everyone. Everyone in this community, I think, has my cell phone number. And I've called and say, how can we help? This is a resource we can bring. So it's been county officials. It's every area of business. This is how we can support what you're doing. During a time of crisis, really when the bullets start flying and people they know are falling ill, everyone bands together. I wish I could tell you there was one way we did it, but that is just the community coming together to support each other in a time of crisis.
That's very reassuring and very inspiring, and it's great to hear that that's how it works in your rural community. Is the trauma taking a toll on the emotional well-being of your staff, and what can you do to help them through this crisis?
I really worry about what the staff's going through. They're seeing otherwise healthy patients come in and become subject to this disease very quickly. They're going to work courageously every day, knowing there's a possibility they could become infected themselves or they could bring it back to their families. We've had 12 of our team members test positive already and fall ill to it. It's something that you wake up every day and think, now I've got to gather my courage and go back to it. The best way we've dealt with that from a crisis standpoint is really keeping them informed of this is what's going on. We do regular communications, and frankly, in the past, I would do an email or this is what's going out or inform the managers. We do a 3 to 4 minute video every day, myself or one of the other leaders. This is what's happening. This is what we're doing. For good or bad, we want them to be informed, and that's really been helpful from their standpoint. In addition to that, we've had our psychologists and psychiatrists do videos as well. This is what you need to watch for. You need to support each other. And I think as an industry, we need to realize this is going to lead to some long-term traumatic effects on our frontline team. This has been difficult. We've had a small community in Franklin County with 2,500 people in it, and I know 4 or 5 people who have died of COVID live in that community. It's affecting a lot of us, and we know people that this disease has impacted. I think this is just going to be a long-term trauma situation we're going to have to deal with and stay abreast of what the needs are from our staff's perspective and make sure we address them. There's also financial challenges, and we're dealing with that as a hospital as we're seeing our revenue drop 50% or more. How do we make sure that our team doesn't suffer financially on top of the heroic work they're doing? All of those play into how to keep the trauma at bay for right now.
We hear your crisis, we hear how you're managing through this, and know that those of us at AHA and across the country are here to support you through it. You said your first patients presented on March 13th. It's been over a month since you began your battle with COVID-19. Where are you now in this battle, and where do you see it heading?
There's always talk in the region and throughout the country of peaks and surges and things of that nature. We saw our highest volumes of 9 or 10 patients a day toward the end of March. Now we're seeing more like 2 to 3 patients a day present here. To give you an idea, in our region, the 3-county region we serve has 78,000 people in it. 1 in 250 have tested positive here. To give you an idea, California's got 22,000. patients that have tested positive. If they had our ratio, that would be 158,000 people. So we've got a lot of intense disease here. Over a third of the patients that we test end up being positive, and you can kind of compare those to the stats across the country where generally it's much less than 20%. Honestly, I think this is a disease. I think it's like cancer or influenza or heart disease, anything else we treat. I think we're just going to have to deal with it like a disease. Once testing becomes more available, once it becomes more accurate, once we have drugs that actually work at treating this disease and find other treatments that work, I think we'll just realize it's a disease with us, and that's how we're going to have to treat it and how we'll have to handle it going forward.
Tim, Margaret Mary Health has been the picture of resilience and resourcefulness that we know is characteristic of rural healthcare. I have one final question. What advice can you give your colleagues that will help them prepare for COVID-19?
Well, I guess for my rural colleagues, the one thing I'd like to share is that you'll know a lot of people that come in with this. When you get hit and hit hard, one of the things that's been hard for us is having husband and wives both fall ill or whole families fall ill with this disease and be admitting on our inpatient unit. That makes it tough for all the staff to see people they know impacted like this. In general, for hospitals across the country, there are no competing hospitals at this point in time. We are all in this together and lean on each other, transfer a little bit more than you would have before, be a resource for other hospitals, share equipment or PPE when there's shortages, be able to work together. The last thing I'd say for leaders in general is we all set up our command structure and incident command and mass casualty situations. Those are all pretty generic. When the bullets start flying and people get really scared and your volumes jump in the emergency department, you'll find a couple of things happen with your leadership team and your frontline staff, and just be ready for it. Many will rise to the occasion and think beyond their job and really be outstanding, and some will just be so paralyzed with fear. They're all good people and they all do a good job on a regular basis. But when it gets really tough, you need to recognize the people that are absolutely paralyzed and work to be able to assign duties around them so they're not bogging down the entire system. And it surprised me who becomes paralyzed and who doesn't. But it's something as leaders you need to realize is going to happen even in yourself and be able to adapt to it to get the job done.
Tim, I can hear the compassion and the concern in your voice for your staff and your neighbors, and it's greatly respected. The strength of rural healthcare is critical to the fabric of American healthcare, and it is our mission to safeguard it, improve it, expand it, and advance it for future generations. Thank you to our country's healthcare providers for their hard work, dedication, and sacrifice in this trying time. And thank you to hospital and health system leaders like Tim Putnam, CEO, and the nurses, physicians, and all healthcare heroes caring for patients at Margaret Mary Health in Batesville, Indiana, and across rural America. This is one of several stories of how rural hospitals are rising to the challenge of COVID-19. Visit our website at www.aha.org to access these and other COVID-19 resources available to hospitals and health systems. Thank you. I'm John Supplett. Be safe and stay well.